Ma'am, you can turn on your camera so that we can go live. Ma'am, we are live now. It's already 3. With all your permission, I'm starting this session.
Yes.
Good afternoon, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Arati Nayak ma'am. Ma'am has done MD, FICOG, FMAS, FICMCH, and Diploma in Urogyne and Senior Obstetrician and Gynecologist Specialist at BMC Hospital, Bhubaneswar, Odisha. Today, ma'am is going to discuss on a topic, menopause and its management. Let me tell you overview of the topic. Menopause is a natural biological process that marks the end of women's reproductive years. It occurs when a woman's ovaries stop producing eggs, leading to a decrease in the production of estrogen and progesterone hormones. Menopause typically occurs between the age of 45 and 55, but can occur earlier or later in some women. The management of menopause focuses on alleviating symptoms and improving overall quality of life. To know more about this topic, I would like to invite ma'am and hand over this session to ma'am. Over to you. Kindly proceed from here, ma'am.
Good afternoon, all. Respected all doctors and delegates present over here. Well, thank you all for having me in this platform. My topic is menopause and its management. As all of you know that menopause is cessation of menstruation due to degeneration of ovarian follicles. It is due to gradual diminution of ovarian follicles, and there is more rapid decline in ovarian follicles, which starts in late 30s and 40s and continue up to a point when menopausal ovary is virtually devoid of follicle. Actually, what happens due to influence from higher center, the median arcuate nucleus of hypothalamus produce gonadotropin releasing hormones, which act over the receptor that present in the pituitary, and from pituitary there is release of gonadotropin hormones, which stimulate the ovary, and from ovary there is production of ovarian steroidal hormones, that is estrogen and progesterone. It has got both positive and negative feedback effect on the pituitary. Ovary also produce inhibin, but inhibin has got only negative feedback effect on the pituitary. In the initial part of the menopause, the inhibin concentration reduces, and so there is no negative feedback effect on the pituitary. So there is monotropic rise in the FSH production from pituitary, which accelerates the follicular phase of menstrual cycle and causes high basal estradiol and menstrual irregularity. After menopause, granulosa cells gradually lose their ability to produce estradiol. AMS level decreases markedly and progressively, which is produced from the antral follicles. One of the important features during menopause is vasomotor symptoms. The cause remains an enigma. There is some dysfunction at thermoregulator nucleus of hypothalamus. Probably the estrogen withdrawal or rapid fluctuation of estrogen level is the culprit. Another thing is alteration of neurotransmitter, that is norepinephrine and serotonin, responsible for this vasomotor symptom. Actually, what happens, there is sudden wave of heat with sweating that spread over the body, particularly in upper body and face, and there is increased skin temperature. 5 to 9 minutes after hot flush begins, the core temperature declines, that is 0.1 to 0.9 degrees centigrade, due to loss from perspiration. and increased peripheral vasodilation. Skin temperature gradually returns to normal, sometimes taking more than 30 minutes. One important issue during menopause is bone loss. As all of you know that bone is a living tissue, dynamic tissue. There is a good balance between osteoblastic activity and osteoclastic activity. The peak bone mass occurs between 25 years to 35 years of age. After 35 years till menopause, there is loss of around 0.4% bone per year. And from menopause to 10 years, there is loss of around 2 to 5% per year. And after 5 years, it remains it remains static. This is regulated by receptor activator of nuclear factor ligand pathway, popularly known as Rankel pathway. During reproductive period, due to high estrogen, there is more osteoblastic activity, so bone formation is more. And during menopause, the estrogen level decreases, there is more osteoclastic activity, so there is bone resorption. What are the changes that occurs in the lower reproductive tract that is known as genitourinary syndrome of menopause? Normally, estrogen receptors have been identified in vulva, vagina, urethra, and pelvic floor musculature. Without estrogen, vagina loses collagen tissue, adipose tissue, and ability to retain water. As vagina wall shrinks, ruga flattens, vagina attains smooth wall, pale pink appearance. Surface epithelium thins and mark reduced ratio of superficial to basal cell. Vaginal surface become friable and prone to submucosal petechial hemorrhage and bleeding with minimal trauma. Vaginal pH becomes alkaline instead of acidic and less hospitable to lactobacilli and more susceptible to infection by urogenital and fecal pathogen. The prevalence of bacterial vaginosis is increased from 23 to 38%. Subcutaneous fat at labia majora lost, leading to shrinkage of clitoris, prepuce, and urethra. There is slight increase in stress incontinence or incontinence due to shortening associated with atrophic changes. So that leads to there is dryness, burning sensation, irritation, and absent lubrication, and that causes dyspareunia. And urinary symptoms like urgency, dysuria, and recurrent UTI is more common during menopause. One of the worst things that happens during menopause is weight gain and fat distribution. Women aged around 45 to 54 years has significantly greater increase in weight and hip circumference. And weight gain during this period causes fat deposition in viscera and abdomen that causes increase in visceral fat, leading to insulin resistance and metabolic syndrome. What are the dermatological changes that occur during menopause? Because of low estrogen, there will be low collagen content, decreased sebaceous gland secretion, and loss of elasticity that causes hyperpigmentation of skin, wrinkling, and itching. What are the dental changes that occurs during menopause? There will be atrophy of buccal epithelium. There will be decreased salivation, increased cavities, tooth loss due to oroalveolar bone loss. Breast changes, there will be due to decrease in estrogen and progesterone that causes reduction in volume, tissue density, and which are replaced by the adipose tissue. Then sleep dysfunction and fatigue that occurs during menopause. There is a direct relationship between hot flushes and impaired sleep. There is decrease in quality of sleep, and the sleep is easily awakened by pain, bodily urges, sound, and light. Sleep disturbance, sleep disorder breathing due to pharyngeal obstruction are more common and often associated with increased BMI and decreased estrogen and progesterone levels. And due to disturbed sleep, there will be fatigue, irritability, and cognitive dysfunction. Cognitive dysfunction, that is decline in memory, has no correlationship with estrogen deficiency, but progesterone and sex hormone binding globulin levels are more positively associated with cognitive dysfunction. Psychological changes. Menopausal transition is a complex social, cultural, as well as hormonal event, and the risk of depression increases to 2.5 times due to illness of parents, separation of the kids, and husband health issue. For multiple issues, the risk of depression increases to 2.5 times. Then dyspareunia, sexual dysfunction, and libido. Dyspareunia is generally attributed to vaginal dryness and mucosal atrophy. There will be urogenital problem, prolapse, incontinence, and other causes of sexual dysfunction. Pelvic floor hypotenuse dysfunction may cause pain in deep penetration. Significant psychosocial and physiological changes occurring simultaneously, like arthritis, hip and lumbar joint pain, fibromyalgia, chronic pelvic pain, that leads to sexual dysfunction. One of the important issues during menopause is osteoporosis. I'll discuss osteoporosis in detail. Osteoporosis is a systemic skeletal disorder that characterized by loss of bone mass, microarchitectural deterioration of bone tissue, leading to bone fragility and consequent increase in bone fracture risk. It leads to abnormally porous bone that is compressible like sponge. The spine, the hip, the wrist are the commonest areas of bone fracture from osteoporosis. According to International Osteoporosis Foundation, 1 in 3 women over 50 may experience osteoporotic fractures and 1 in 5 men. There are two types of osteoporosis. One is primary, another thing is secondary osteoporosis. Primary, again, two types. One is type 1 and type 2. Type 1 occurs in postmenopausal women, and type 2 is associated with osteoporosis. Secondary osteoporosis is loss of bone caused by an identifiable agent or disease, such as inflammatory disorder or bone marrow cellularity disorder and corticosteroid use. Osteoporosis is often called the silent disease, as many people don't recognize they have it until a fracture occurs. And fracture caused by osteoporosis are often painful, and there will be back pain, which will be either episodic, acute, low thoracic or high lumbar pain. There will be decrease in height, kyphosis, Dogersam, and decreased activity tolerance. There are some non-modifiable risk factors, some modifiable risk factors. The non-modifiable risk factors includes advancing age, female gender, premature menopause, and family history of osteoporotic hip fractures or personal history of fracture as an adult. And modifiable risk factor when there is low calcium or vitamin D intake, sedentary lifestyle, cigarette smoking, alcohol intake, or excessive caffeine intake, low BMI, and estrogen deficiency. There are two tests. One is occult thoracic vertebra fracture test and occult lumbar vertebra fracture test. In occult thoracic vertebra fracture test, the patient is asked to stand by the side of the wall. Normally, there should not be any gap between the occiput and the wall. If there is a definite gap between the occiput and the wall, it indicates the occult thoracic vertebra fracture test is positive. And in occult lumbar vertebra fracture test, if it introduces more than 2 fingers between the rib and the pelvis, then it is normal. If it introduces less than 2 fingers, then occult lumbar vertebra fracture test is positive. What is FRAX? That is fracture risk assessment tool. FRAX is a fracture risk assessment tool used to evaluate the 10 years probability of hip and measure osteoporotic fracture risk that integrates clinical risk factors and bone mineral density at the femoral neck. When FRAX score is less than 10%, it is low risk. When it is 10 to 20%, it is medium risk. And when it is more than 20%, it is high risk. What is OSTA? osteoporosis self-assessment tool for SCNs. It is a simple clinical screening tool that based on age and weight of the lady, postmenopausal SCN. Women in the high risk category and those in the moderate risk category with additional risk factors for osteoporosis should be recommended for DEXA scan. This graph suggests with increasing age of the patient and with low BMI, the risk of osteoporotic fracture is very high. Bone mineral density test, it is the commonest test we are advising during menopause, and the results are expressed in T-scores. T-scores are relative to how much higher or lower your bone density is compared to that of a healthy adult. Normal bone mineral density is more than -1, and in case of osteopenia, it is between -1 to -2.5, and in osteoporosis, it is less than -2.5. For early diagnosis, we can use X-ray, BMD by photon absorptiometry, quantitative CT scanning, and quantitative ultrasonography, and bone turnover markers. Radiography, it is highly subjective. Unless bone loss is more than 30%, it is difficult to visualize by radiography. Photon absorptiometry, either single photon absorptiometry or dual photon absorptiometry is used, that is DEXA scan. 2 photoelectric peaks are quantified and device is able to subtract the contribution of soft tissue. Quantitative ultrasound measurement is non-invasive test, low cost, and less operation skill is essential. Bone turnover markers also used. There are some osteoblastic markers, there are some osteoclastic markers. Bone turnover markers are used for monitoring of effectiveness of therapy. Lab test, we can advise ESR, bone profile, that is serum calcium, phosphate, and albumin, alkaline phosphatase, and renal function. What are the goals of physiotherapy management? The goals are to educate proper posture of the patient, teach safe ways of moving and lifting, to prevent a decline in bone mass and prevent fracture, to increase the strength of bones, to maintain or improve balance, and to improve flexibility, to help decrease the stress placed on the bones by tight muscles, and to improve overall mobility. What keeps bone healthy? For that, we have to do regular exercise. We have to take adequate amount of calcium, that is 1200 milligram per day, and adequate amounts of vitamin D, which is essential for absorbing calcium, that is 400 to 800 international unit per day, and flexibility exercise that helps in stretching muscles, protect against injury, and that allow the maximum range of motion for joints. National Osteoporosis Foundation guidelines that counsel all women on risk factors for osteoporosis and perform BMD test for all postmenopausal women with fractures, and recommend BMD for postmenopausal women less than 65 years with 1 or more risk factors, and all women with more than 65 years. The treatments are either hormonal therapy or medicines like bisphosphonate, selective estrogen receptor modulator, or calcitonin. Then another emerging therapy is WKO therapy. It is a harness with a lightweight attached and specific back extension exercise. The WKO is worn daily for 30 minutes in the morning and afternoon. These are the drugs available for treatment of osteoporosis. The slide is not visible. There are some anti-resorptive drugs. There are some bone-forming drugs and drugs with complex mechanism of actions. The anti-resorptive drugs are bisphosphonate, selective estrogen receptor modulator, hormone replacement therapy, and tibolone and calcitonin. The mainstay of treatment of osteoporosis is bisphosphonate, that is approved in US for osteoporosis. Different drugs of bisphosphonate that available in the market are alendronate, residronate, evandronate, and zoledronate. How to to take this bisphosphonate. This bisphosphonate must be taken in empty stomach with full glass of water, and she is advised not to lie down for at least 30 minutes after taking this drug. What is gaining importance is one IV medication, that is reclast or zoledronic acid. It is given once a year, 15-minute infusion, and which will allow the easiest available intake of an osteoporosis medication with excellent efficacy and a good safety profile. Calcitonin is a medicine that slows the rate of bone loss and relieves bone pain. It comes as a nasal spray or injectable. The main side effects are nasal irritation from the spray. Calcitonin appeared to be less effective in comparison to bisphosphonate for osteoporosis management in menopause. Hormone replacement therapy. Estrogen or hormone replacement is rarely used anymore to prevent osteoporosis. Estrogen is essential for healthy bone, and when the production of estrogen is reduced in postmenopausal women or pathogenically after exposure to radiation or chemotherapeutic agent, bones become brittle and break easily. The new study observed that one way estradiol helps to maintain the bone density is by stopping the activation of enzyme caspase 3, which is the central player in initiating the process of apoptosis or programmed cell death of osteoblast. Yes, osteoporosis Australian guideline is very important slide. The risk of using HRT increase with increasing age. In women below the age of 60 who do not have risk factors for breast cancer, cardiovascular disease, stroke, or venous thrombosis, the risk associated with short-term HRT are very low. Osteoporosis Australian advised that HRT should be considered as a short-term treatment for osteoporosis for women below the age of 60 if other osteoporosis treatment cannot be used. That means HRT can be used for osteoporosis management in women less than age 60 years, where the risk for thromboembolism and cardiovascular disease and stroke is less, and where other osteoporotic management like medical management fails. In that situation, we can use. So women over 60 years who are more likely to develop osteoporosis and experience fracture are also at high risk of cardiovascular disease, stroke, and venous thrombosis. The risk of HRT for these women may outweigh any benefits for bone health. While individual risk will vary, other treatment for osteoporosis such as bisphosphonates or SUMS we can give to the patients. So women over 60 years, even if there is high risk factors for fracture, in that situation we cannot use HRT for treatment of osteoporosis. In that situation, we have to give bisphosphonates or SUMS. Parathyroid hormone is approved for the treatment of postmenopausal women who have severe osteoporosis and are considered at high risk for fractures. Raloxifene is used for the prevention and treatment of osteoporosis. Raloxifene can reduce the risk of spinal fracture by almost 50%. It may have protective effects against heart disease and breast cancer. The most serious side effect of raloxifene is DVT, that is deep vein thrombosis. So how to prevent osteoporosis? We have to do exercise such as walking, running, skipping rope, jogging regularly, add soya in diet. Plant estrogen found in soya helps to maintain bone density and reduce the risk of fractures. Avoid smoking. It can reduce the levels of estrogen and increase bone loss. And avoid alcohol and caffeine intake. 2019 guidelines from Endocrine Society that treat patients who are at high risk, particularly those with previous fractures. Consider bisphosphonate as the first-line therapeutic choice for postmenopausal women at high risk of fracture, and reassess fracture risk after patient has been on bisphosphonate for 5 years. All women undergoing treatment with osteoporosis therapy other than anabolic therapy should consume calcium and vitamin D in their diet or via supplements. Then lifestyle and home remedies: maintain good posture which involves keep the head held high, chin in, shoulders back, and upper back flat, lower spine arch, and helps to avoid stress on the spine. When sit or drive, place a roll towel in the back. Don't lean over while reading or doing handwork. When lifting, bend at the knees, not the waist, and lift with the legs, keeping the upper back straight. Prevent falls, manage pain, and don't ignore chronic pain. Then another important thing about HRT, without discussion of HRT, the menopause discussion is incomplete. HRT is hormone replacement therapy, is a treatment used to relieve the symptoms of the menopause. It replaces female hormones, that is estrogen, at a lower level as you approach the menopause. It includes a wide range of hormonal products, that is estrogen, progesterone, and androgens. According to International Menopausal Society, HRT should be a part of an overall strategy for maintaining the health of perimenopausal women. The dose must be individualized and tailored according to symptoms. We must use lowest effective dose for shortest possible time, that is natural menopause. The current indication of HRT are for treatment of menopausal symptoms, but the risk-benefit ratio is favorable, and that must be fully informed to the woman. And women with premature or early menopause until the age of natural menopause, even if she is asymptomatic. And women under 60 years who are the risk of an osteoporotic fracture, as I was discussing. And for prevention of cardiovascular disease less than 60 years, and for urogenital symptoms. What are types of HRT? We can give unopposed continuous estrogen when uterus is absent, and cyclical estrogen progesterone therapy, where it is given in perimenopausal women, where the woman is still menstruating or last menstruation has occurred within 1 year. Continuous combined estrogen and progesterone is given in postmenopausal women, where the last menstruation has occurred beyond 1 year, and local estrogen when there is risk for risk of embolism, thromboembolism, or when the woman is smoker or alcoholic or cigarette smoking. The routes of administration we usually advise are oral route or transdermal route or vaginal route or nasal spray or local device such as progesterone, that is intrauterine system. The advantage of oral preparation is it is cheap, easy to take, and the disadvantage is it needs high dose and there is fast pass effect, and we have to take it daily. The advantage of transdermal preparation are it needs low dose and we can avoid the fast pass metabolism, and the thromboembolism risk is less. The disadvantage is it is costly and sometimes it causes allergic reaction, and there is possibility of variable absorption. Variable preparation of estrogen and progesterone are available for HRT. The conjugated estrogen, the standard dose is 0.6 to 5 milligram. We can use up to 1.25 milligram also. Commonly used drug is estradiol valerate. The standard dose is 2 milligram. Vaginal estrogen, the advantages are it is useful for atrophic vaginitis, and the disadvantage is there is erratic absorption and there is possibility of endometrial hyperplasia. We cannot use vaginal estrogen beyond 1 year because after 1 year, the vaginal estrogen is equivalent to 1 tablet daily orally, and its action over the breast is not known. So vaginal estrogen should not be given beyond 1 year. If a woman on HRT, we have to give importance these things. If there is bleeding, heavy or irregular on sequence shall combine HRT, then the dose of progesterone can be doubled or increased in duration to 14 days instead of 10 days. When erratic bleeding can be common in the first 3 to 6 months after starting HRT. But women with persistent vaginal bleeding, even after 6 months of starting HRT, that needs evaluation. Women with progesterone side effect like weight gain, fluid retention, or depression, or mood swings, then the progesterone dose is either reduced or the duration of progesterone therapy is reduced to 7 to 10 days. And less side effect is seen with preparation like dydrogesterone, micronized progesterone, and intrauterine system like Mirena. What tests are needed before starting HRT? It should be given, the woman must be less than 60 years. We should collect medical history completely, and we have to ask the year since menopause, and we have to see what are the indication, what are the contraindication of this HRT, and discussion of risk and benefits with the patient. And we have to do physical examination completely, that is blood pressure, breast and pelvic examination, and DEXA scan, vitamin D, pap smear, MRI, mammography, if it is essential, will advise, and serum lipid profile. And if there is risk for thrombophilia, then thrombophilia profile is done. And endometrial biopsy, if there is erratic bleeding after 6 months or increased thickness of endometrium, which is suggested in transvaginal sonography, then endometrial biopsy is advised. Then follow-up. First follow-up is done after 3 months. When a woman is on vaginal estrogen, then the response starts at 1 month, and maximum response occur after 3 months. So first follow-up is done after 3 months. Then every 6 to 12 months, once it is titrated. Breast and pelvic examination should be done yearly. Mammogram should be done yearly, and endometrial biopsy if it is essential. There are some estrogen-related side effects. There are some progesterone-related side effects. The estrogen-related side effects are nausea, indigestion, and skin irritation, breast tenderness. The progesterone-related side effects are weight gain, fluid retention, bloating, depression, mood swings, the worst complications seen with progesterone. Then what are the risks with HRT? The important thing is cardiovascular, that is thromboembolism, venous thromboembolism, pulmonary embolism, stroke, and coronary heart disease, malignancy, breast cancer. When combined estrogen and progesterone preparation are used for more than 5 years, and endometrial cancer risk is increased when estrogen is alone used for HRT. The endometrial cancer risk is very high. Other risk factors of HRT, other risks associated with HRT are Alzheimer's disease and gallbladder disease. Breast cancer, when combined estrogen and progesterone combination are used for more than 5 years in lean women, women more than 60 years. And the good news is that mortality from breast cancer is not significantly increased in an HRT user. After 3 to 10 years of use of HRT, the risk of endometrial cancer increases 3 to 6 fold, and after 10 years of use, the risk increases to more than 10 folds. But addition of progesterone for 12 to 14 days or more per month, that reduces this risk. Tibolone does not increase the risk of either endometrial hyperplasia or endometrial cancer. HRT and heart disease. Women who are over 60 years and take HRT for more than 10 years after the menopause have an increased risk of heart disease. But according to NICE guidelines, HRT does not increase the cardiovascular risk when started in women aged under 60 years. In fact, in women within 10 years of the onset of menopause, the administration of HRT decreased the rate of coronary artery disease. As you know that estrogen protects the heart. HRT and stroke. Recent study revealed a smaller increase in incidence of stroke in women who commence HRT between the age of 50 to 59. The effects of HRT on stroke may be dose related, and so the lowest effective dose is usually prescribed in women who have significant risk factors for stroke. The short-term use for HRT are for heart pulses, for vasomotor symptoms, for dyspareunia and urethral syndrome, and long-term uses of HRT are for osteoporosis, for Alzheimer's disease and cardiovascular disease. How to start this HRT? It must be started in lowest effective dose for minimum duration, and most benefits are seen if started in early in menopause, and it must be started in low dose and increase after 4 to 6 if the symptom persists. First line therapy is always oral estrogen, and if there is a risk for venous thromboembolism or cardiovascular risk, then transdermal estrogen can be given. In case of hysterectomy patients, estrogen alone is used, and intact uterus, combined estrogen and progesterone preparation are used. When to stop HRT? Most guidelines recommend safe up to 5 years. There is no clear consensus on how to stop the therapy, and many trials have shown that recurrence rate is same with tapering or abrupt stoppage. Then what are the benefits of HRT? For most symptomatic women, use of HRT for 5 years or more is safe, and 5 years or less is safe and effective in women less than 60 years. It is helpful to reduce vasomotor symptom. It improves the quality of life, improves the urogenital symptoms, improves the mood changes, and reduction in osteoporosis, reduction in cardiovascular disease and colorectal cancer. So coming to the summary, clinical goals during menopausal transition are to optimize women's health and well-being during and after this transition. This is an excellent opportunity for comprehensive and health evaluation. Because of increasing life expectancy, osteoporosis is fast becoming a global problem in the elderly. So maintain an active and healthy lifestyle. Never too late to start exercise. Regular calcium and vitamin D3 is helpful. Bisphosphonate is the first line therapy. And HRT in selected postmenopausal patients less than 60 years. Current guidelines should enable clinicians to feel more confident about offering HRT to eligible women. They should also be able to help women to make a more informed choice regarding their treatment, which can now be based on a more balanced review of the evidence. Thank you. Thank you all. Thank you for.
Thank you so much, ma'am, for giving your valuable time and sharing your knowledge with us and making this session informative one, ma'am. I definitely think this session knowledge is going to help all the participants who have joined this session. And I want to thank you because you have taken out this time, precious time you are suffering from at your area wind after not having a power cut also you are available, ma'am. That means a lot for us. And ma'am, we have received some question from the participant.
Yes.
If you allow, can I take this question?
Yes. Yes.
Yeah, the first question I can see is the what does menopause increase risk of heart disease?
After 60 years, as I was telling, estrogen is cardioprotective. Till estrogen, it is there, it is it will protect our heart. So use of HRT after 60 years is contraindicated. So we can use HRT before 60 years. So it is a cardioprotective. Estrogen is a cardioprotective.
Okay, thank you so much, ma'am, for answering the question, ma'am. We are moving forward. I can see another question. The question is how is HRT administered in the treatment of menopausal symptoms?
I was telling as there are oral preparation are there, vaginal preparation are there, and transdermal preparation are there. If a woman is not having risk like thromboembolism, or there is breast any breast complaint or cardiovascular risk or stroke, in that situation we can give HRT, and in HRT we can use estrogen, progesterone, or androgens also there. And if there is high risk for stroke or cardiovascular or thromboembolism, then in that situation we can use transdermal or transdermal preparation or transvaginal preparation, transdermal preparation. Because in transdermal the fast pass effect is very less. Oral
Okay,
preparation, different oral preparations are available. That is conjugated equine estrogen. The dose is 0.6 to 5 milligram. And commonly used via estradiol valerate. The standard dose is 2 milligram.
Okay, thank you so much, ma'am, for explaining it really well, ma'am. Moving forward, I can see another question. The question is, what are the NAMS recommendation on the symptomatic vulvovaginal atrophy, that is VVA, in the postmenopausal woman?
Yes, in that situation, if there is no risk of endometrial hyperplasia, and in that situation, we can give vaginal estrogen. And vaginal estrogen, the preparation can be available are gel, cream, etc. And one thing I want to tell here, vaginal estrogen we should not use for more than 1 year, because after 1 year, it is equivalent to 1 tablet daily orally, and its action over the breast is not known. So vaginal estrogen should not be given beyond 1 year.
Okay, thank you so much, ma'am, for answering it really well. We will be taking last question for today's session. And the question is, what is the association between breast cancer risk and HRT of menopause?
Yes, as I was telling that if combined preparation of estrogen and progesterone is used for more than 5 years in lean women, and that too beyond 60 years, the risk is very high. Combined preparation of estrogen and progesterone for more than 5 years, that too in lean women for after 60 years of age, the risk is very high. But the good news is that mortality from CA breast by using HRT is very less, because it is localized. It will not spread.
Okay, thank you so much, ma'am, for answering all the question really well. I hope that all the doubts of the participant has been clear. As there is no more question from the participant end, shall we conclude this session with all your permission, ma'am?
Yes, Bharat. Yes, thank you. Thank you so
Okay,
much.
thank you so much, ma'am. Take
Yes,
care,
yes.
ma'am. Hope to see you again with